you, Klaus, for inviting me to return to this great hospital. It was about 27 years ago, I think I saw Gantz do the PAO demonstrated to us, and I embarked upon my interest in PAOs. So I'll talk to you about results and complications of PAO. I would like to credit my co-authors in the University of Adelaide and Royal Adelaide Hospital. I was asked to actually direct this presentation to surgeons who might be early in their career in PAO surgery or considering PAO surgery, and those undertaking PAO in relatively small numbers, which does occur because of geographical isolation or because of the type of health system that you work in. PAO, as we know, is described by Gantz, who reported good results, but other surgeons reported technical difficulty with the single anterior approach, learning period problems, and major disabling complications. And there are many references to those problems. We have previously demonstrated that PAO can be learnt by structured mentorship, although there are better ways to learn now that there are more PAO surgeons. So the aim this time is to determine whether PAO skills can be maintained in such a low volume setting when there is continuing mentorship and review, and I'd like to acknowledge Gantz, Beck and Santori for their support. I was also asked to discuss changes made to PAO and focus on changes in response to our complications, and that in the literature. So I'll focus on the posterior column osteotomies during PAO and briefly mention some of the intraoperative issues with imaging. The patient cohort is 90 hips in 73 patients with a median age of 27. PAO, the anterior approach, was according to Gantz, and with an additional arthrotomy and femoral neck osteoplasty for many years. No arthroscopic label treatment was undertaken, and the first 10 cases had a double approach to avoid posterior column problems. This is the first patient in 92, a simple dysplasia case at 25 years, confirming they have very good results and here are good joint space. The cases actually were simple DDH in 57 and complex dysplasia in 33. So a third of the cases or more were complex because they either had Perthes or other diagnoses, they had quite abnormal femoral heads or abnormal femoral head-neck anatomy, that had previous surgery, or they underwent simultaneous femoral osteotomy in 14. These complex cases, as an example, we're seeing more and more. This is a Caput Flexum deformity with severe dysplasia, and you can see in the model, the femoral head points 70 degrees anteriorly. And these types of complex cases clearly now require the capability for surgical dislocation, types of osteotomies of the femur, and increasingly subtrochanteric rather than intertrochanteric osteotomy in association with PAO. What are the clinical results? All patients were prospectively monitored. We only lost 2 hips in one patient to follow up. That's the advantage of a geographically isolated area. They don't leave. Patient outcomes, the Harris hip scores, the usual pre-op 58, increasing at 10 years to 86. The Tonnis OA grading for that simple DDH group, you see in the pre-op and post-op not much change in the 0s and 1s, and even in the grade 2s, there were 6 post-op instead of 4 and up to 25 years, and 1 patient had deteriorated to a grade 3. The major complications, grade 3 and 4, according to the SYNC grading. Grade 3, we had 6, but actually 1 was screw removal and 2 were complications of those complex femoral osteotomies. Grade 4, we had 0, so no permanent nerve injuries, intra-articular hinging problems, vascular injuries. And that's about similar to what the Clohissy report was, but they'd excluded the learning curve. So we're happy with those results. If you look at the major reoperations in the 90 PAOs, there were 3 reosteotomies, and actually 2 of those you could probably attribute to imaging issues. I'll mention those. There were 3 osteectomies for FAI, so we feel, therefore, 2 of those were very late and in complex cases, so we are still comfortable not to undertake arthroscopic surgery at the time of PAO. 1 infection, 1 tissue flap, and 6 total hip replacements in this group of 90. If you look at survival to endpoint for total hip replacement, you see 20 cases available at 12 years and a survivorship of 94%. That's 90% on worst case analysis. The survival for these PAOs at 12 years is 94%. It's similar, or it's better than some of the 5 studies that had similar follow-ups at a median of 10 years. The other complications, 2 temporary nerve palsies, both recovered completely within 2 months. 1 femoral palsy, which was a message because the patient had a previous psoas redirection through that hole in the ilium that you can see on the 18-year X-ray. And 1 sciatic nerve in association with a posterior column fracture. Both had full recovery. Posterior column complications are worth mentioning because we had a fracture in 7 and an ischial non-unions in 2. So not insignificant. Some people don't worry too much about most of them, but they are a concern. Posterior column complications actually were reported in up to 14% of early series. They're still reported in recent series, and fractures are probably under-recognised and only seen if you do CTs post-op, and they may well contribute to that high incidence in some series of pubic non-unions and pubic so-called stress fractures. I'll therefore discuss these posterior column osteotomies because I was asked to focus on something related to a change that we made because of a complication. So the change was the introduction of fluoroscopy and the order of osteotomies and incorporation of other surgeons' techniques. And I'll just run through those. So the inferior ischial cut has been a problem in the literature. It was a problem for me early because of complete ischial osteotomy, but others have reported fractures, non-unions, joint injuries, incomplete osteotomy, which then causes failure of rotation, and that, or if you force the rotation, you may see a fracture of the pubis. The solution is, I think, worthwhile doing, and that is a fluoroscopic 30-30 view for the site, but not the depth, and then to palpate the osteotome tip inside the pelvis for depth of osteotomy. I think that's quite a useful approach. The inner pelvic brim of the ischial, at the ilio-ischial line seen there in yellow, is actually a problem. You can see the bone between the ilium cut and the posterior column is of variable thickness and orientation, and it's often very sclerotic. Osteotomy or fracture may propagate into the greater sciatic notch, and if you look in the literature, it's clearly a potential site for intra-articular osteotomy. The solutions are either to control the direction of the osteotome under fluoroscopy, or after the ilium cut, to actually first go to the posterior column osteotomy as recommended by Keith Mayo inside the pelvis, then return to the pelvic brim and join the osteotomies under direct control. And I use a high-speed pencil burr. I think Mast may have used it, but it's a very useful way to control that osteotomy. And then make sure you develop the inner column osteotomy distally before you go to the outer cortex. So bearing in mind that fluoroscopy has helped, the second thing I want to briefly talk about is the type of imaging that one uses to judge correction. 10 years or more ago, we introduced fluoroscopy for intraoperative imaging and standing AP radiographs. But at that time, identified problems when you started to combine these new imaging or experience with this new imaging. And in fact, we identified firstly that fluoroscopy was actually a PA view, which wasn't well appreciated in the literature or often by surgeons. In fact, you can see this early study looking at the PA and the AP, and the PA projection clearly increases the posterior wall prominence. I actually then surveyed PAO surgeons of the Hip Society and found that there were these big differences internationally in the techniques that people use, and the effect of these differences were actually not necessarily appreciated, including that you're using a PA fluoroscopy view. So I think it's worthwhile continuing to think about these variables when you're correcting. The variables on an AP X-ray are that when the patient stands, though the pelvis reclinates on supine to standing, causing anterior undercovering. Importantly though, if you look at the data, there is a large variation in the amount of reclination. And some patients actually inclinate their pelvis when they stand, so causing potential for over-coverage and impingement. The other variables to consider are changes in anterior hip cover during fluoroscopy. It is influenced by the side of the beam. The study here showed whether you center on the pelvis or the hip. It's influenced by the tilt of the beam, and we've found that it's influenced by the initial pelvic inclination on the table. So currently I do an overkill. I use pre and post-operatively AP pelvis supine and standing radiographs, and intraoperatively, having used PA fluoroscopy to help me balance the correction, I then add an AP pelvis X-ray to try to get as good a combination as I can to achieve a standing correction post-operatively. So in summary, I've found the complex dysplasia I'm seeing more commonly. I do small numbers of PAOs and I'm seeing less of the simple dysplasia. I think you need the capability to go on and do that simultaneous femoral surgery. PAO can be safely undertaken in small numbers, but mentoring is a critical part of that process. Our clinical and radiographic results are actually as good as the better series. Therefore, I think the likely complications I've talked about are relevant to practice, including the posterior column. And the posterior column osteotomies, for me, have been significantly improved by the introduction of fluoroscopy and a change in the technique and the order of the osteotomies. Finally, I'd suggest that if you do add fluoroscopy, and many people are, and then if you combine it with standing radiographs, it will be particularly useful to you, but it can cause confusion and you need to understand the limitations of different types of imaging. Thank you.